Welcome back to TV47 News tonight. Thank you for choosing your channel of choice, the county's television. Now, cancer registries are a key component in the treatment, care and management of cancer patients across the world. However, except for a few counties, Kenya does not have a national cancer registry as at now. In a special interview, our health reporter Zainab Mohammed speaks to a researcher from Mount Kenya University who is taking the lead in the development of cancer registries in Machakos and Kiambu counties. Tonight, I leave you with that interview.
It is the most dreaded ailment of our time. If it doesn't kill, it leaves the patient in a forlorn state and the family staring at a gaping financial hole. Yes, you're right. I'm talking about cancer in Kenya. Cancer is killing more people than COVID-19 and HIV combined. But the shocking part is that most counties do not have a cancer registry to help them alleviate the cancer burden. But there is hope for two counties, Machakos and Kiambu County. And as the world marks Cancer Day today, I had a sit down with the hope bearer, Dr. Francis Makokha of Mount Kenya University. Dr. Makokha, welcome. Kindly start by telling us what you do at the university.
I work in the Directorate of Research as the head Human Health Research Program and also coordinate the Ethics Office of Mount Kenya University. So in the capacity of Human Health Research Program, I also work on various projects, support the staff in carrying out various projects, but I also have my own research interests which fall on cancer. So basically I focus on cancer, breast cancer, and I also focus on the collecting data about cancer cases to understand the burden of cancer in the country.
What is a cancer registry?
A cancer registry is a collection of information about cancer patients. For instance, when you go to a health facility, they'll send you to a records office. So the records office is a registry that has information about all patients visiting that particular hospital. So we are talking, a cancer registry therefore has collected information and put it together about cancer patients in either in a facility, a particular hospital, or in a region.
What prompted you to start or to embark on the cancer registry for Machakos and Kiambu County?
Basically, as I followed my interests in cancer research, I realized that it is difficult to understand the exact burden of cancer in Kenya because we don't have sufficient data collected about the cancer patients throughout the country. So one of the reasons is that I wanted to understand the burden of cancer, and also I wanted to understand the patterns of cancer itself. So which cancer is found in which locality, and it's difficult to explain based on the rudimentary information that we have. Number three is that we wanted to supplement the efforts of the Nairobi Cancer Registry led by KEMRI and also Eldoret Cancer Registry at Moi Teaching and Referral Hospital. These registries collect information that is of residents within their regions, within their locality. So, for instance, Nairobi Cancer Registry has information on cancer patients who are residents in Nairobi, and they have stayed in Nairobi for the last 10 years. So those are considered to be residents of Nairobi. The Eldoret Cancer Registry has information on patients who hail from Uasin Gishu, Nandi, and around Marakwet, Elgeyo Marakwet counties. So those, you find that this is the information that we have, the figures that we have, but patients from other counties are not covered. So I thought we would supplement those efforts.
Okay. Yes. So how far have you gone with the two projects, and what is the end game?
So we are looking at the cancer cases in Kiambu County and Machakos County. For Machakos County, we have collected the data from their health facilities for all the cases that were treated, cancer cases treated in the last 5 years. And we have put all that together into a software that is supplied by the World Health Organization in a department which is called International Association of Research on Cancer. It is housed in France. So these are the ones who have set up the standards for setting up registries. And so we have collected that information and conformed to the standards set by IARC. And this registry is ready for launching. So it is updated up to the end of, up to December 2020. We have updated information. So now we plan to hand it over to the county so that they can decide on when to launch it. Yes, it's ready for use, and if the information is available upon approval from the relevant authorities in the county Department of Health.
I understand the registries are in two types. There is the population-based and the hospital-based. Could you kindly expound on that?
Yeah, thank you. Our population-based registry is a repository of information on cancer patients in a defined geographical region. So in our case in Kenya, it's a county. So if every county has information about the cancer cases within of residents in that county, then they have a population-based registry. Now, this population-based registry will help you understand the patterns of cancer, which type of cancer is affecting which population, and even which region is most affected. Then, so you are able to understand the trends of cancer. Is this particular cancer increasing within the region, or is it decreasing? Now, hospital-based registry is one that has information about cancer patients attending that specific registry. Now, this will have all the patients as they come in and they go out, regardless of their area of residence. So it will just note this is from, if you take Kijabe Hospital, which treats patients from all over the country. So they'll note this is from maybe Kiambu County, this is from Nyandarua, this is from Nakuru, this is from Nairobi, Machakos. They'll just record that, but they want to understand who are our clients. Can we plan for them? How can we invest so that we serve the clients better? So if they have that information helps them to plan ahead and prioritize again if in terms of training their staff or hiring the staff, because some of these require very specialized treatment, oncologists who are well trained. It will require surgeons who have experience. So the hospital authority needs to plan for that.
So now how will the two cancer registries complement the national registry?
So the information from the county cancer registry can be sent into the national cancer registry. So if all the 47 counties in Kenya had a cancer registry, then it will be very easy at the national, each county to report at the end of the year that in this year we diagnosed this number of cancer cases and these were the types of cancers that we observed, and therefore this helps the planning at the national level. So you have a national registry which can now inform the Ministry of Health in planning and even budgeting for the programs to intervene on cancer treatment.
Since you started working on this project, what gaps have you identified in the treatment and management and care of cancer patients?
There are quite a number of gaps. Lack of comprehensive cancer care centers causes delay from the time the patient is suspected to have cancer to the time they get fully diagnosed and confirmed they have cancer, to the time they start treatment. You'll find that it has taken them 6 months, it has taken them 1 year, movement alone, so it delays, and then it becomes very expensive on the part of the patient. So that delays, and you know, as you delay to commence treatment, the cancer is advancing. So you find that most of our patients start treatment at stage 4, stage 3, stage 4, when it's almost too late to expect for a positive outcome, for full recovery. But if you treat cancer early, before stage 3, then there is hope, there's a very high chance of these patients getting healed and staying cancer-free for more than 5 years, 10 years, and on. So that's one of the lack of the comprehensive cancer care centers in the health facilities. Now, the other gap is the follow-up is not very good. Again, maybe because of the way the management is, because that patient has come for surgery in hospital A, but then they go for chemotherapy in hospital B, then they go for radiotherapy in hospital C. So where are they being followed? So you find that the treatment outcome information is a bit scanty. Not most patients are followed up fully. We lose them to follow up. And treatment requires that you follow this patient for at least 5 years to be sure that they are fully recovered. So apart from that, there's the general problem again in the population. A brief interview with the physicians and the people, the healthcare workers, they'll tell you that some patients miss treatment because of costs. Yes, NHIF is supplementing, but you find that what NHIF gives may not be enough. So we thank the government for the efforts they're making, but they need to put in more so that every patient who is diagnosed with cancer can be treated early enough for us to reduce the mortality rate, the death from cancer.
What other recommendations are you making to the two counties, Machakos and Kiambu, in order to alleviate the disease burden?
I would suggest that the preventive programs, they invest more in preventive primary health care and preventive programs. So educating the public and screening. Now, if you check our topmost cancers in the country. Breast cancer, you'll find breast is either number 1 or number 2 everywhere you go. And then cervical cancer among women. And then esophageal cancer of the throat and prostate cancer among. So those 4, for example, are a problem all over. So if we have programs to try and screen the population for the potential risk, or if they potentially would be developing this, so that we can catch the cancer early. So I would urge the counties to invest in preventive screening programs. And cervical cancer can be screened. And now we have like vaccine for girls, for ladies. So, and treatment, giving vaccines, treatment of infections, because cervical cancer is also an infectious disease caused by infections. So prompt treatment of infections. And for breast cancer, proper screening, educating the healthcare workers and even community health volunteers on how to teach people in the community to do self-screening of the breast. Same to prostate cancer. If this can be done, then it can be a way of trying to detect cancer as early as possible. And therefore, we can be able to treat those cases that are confirmed to be cancerous, and also advise these people on their lifestyle so that we can prevent occurrence of the disease.
I also know that you have another project in the works in matters cancer. Could you talk to us about it?
Yeah, I do have, as I mentioned, that my main area of focus is breast cancer studies, and we are carrying out a study which we have titled Genomic Approaches to Understand Progression of Breast Cancer in the Country. Simply put, is we are trying to understand the genetics of breast cancer. What are the genetic drivers of breast cancer in our patients, in our population? Why we are doing this is most of the studies have been on Caucasian populations in the West, either in Europe or in the US. We don't have data on our own population. So we are trying to have a pilot that will try to understand what are the genetic drivers of cancer in our population. And we also are looking at circulating molecules in blood that are of cancer origin. So these molecules, if we can be able to characterize them, then we can use them for what is called precision medicine. They can be translated to be biomarkers or diagnostics to inform the type of treatment. In breast cancer treatment, there is a test which is called Oncotype. This tests your genes and identifies whether you have so many mutations, and therefore this can help to predict how you'll benefit from chemotherapy. So it informs whether you need chemotherapy, and if you need chemotherapy, what is the precise amount of chemotherapy you need. But this is a very expensive test that requires samples to be sent outside the country. Medicine. So you'll find one patient after the Oncotype test, they will be advised not even to undergo chemotherapy. So they go straight for radiotherapy. And you therefore avoid the side effects that come with chemotherapy. Another patient will be told have 2 courses or 3 courses of chemotherapy, but at this concentration. But that is based on a population that is not Kenyan. So we want to look at, can we make it cheaper? And can we have a domesticated solution that is addressing our population, that has come from our population? So basically that's the kind of study that we are doing. I cannot talk about findings because it's ongoing, and we hope that in the next few months or not so long, we'll have information that can be translated, can be taken to another level. Mm-hmm. Thank you.
Thank you so much, Daktari. Well, that has been Dr. Francis Makokha, and like he promised, the next time we meet, I'll be able to tell you about the genetics project and its contribution to cancer care and treatment. My name is Zainab Mohammed. Thank you so much, and bye.